Over the last 30 years performing aware state spinal surgery, I've learnt that the concept of discogenic pain is misleading. Here I'm touching the exiting nerve in the foramen, and surface pressure on the nerve produces midline and local back pain, and deeper nerve pressure causes dermatomal pain. The annulus only causes local pain, and only if it's inflamed, such as when there is a high-intensity zone. Annular distortion compresses the nerve surface, as when weight-bearing or during discography. The reduced disc turgor, or malposture, produces abnormal microcompressions, irritating the surface of the nerve. Vertebral osteophytes or facet joint osteophytes irritate the nerve surface. Foraminal scarring tethers the nerve and throttles the nerve, causing irritation and nerve dysfunction. And sadly, MRI scans underestimate the degree of that scarring in the foramen. So spinal pain is produced by foraminal nerve distortion or impaction, tethering or breakdown products. Here, the superior foraminal ligament compresses the nerve. The apical osteophyte digs into the nerve. There is tethering between the nerve and the disc, or between the nerve and the facet joint. And of course, all of this is aggravated by disc bulging. Not always by a major protrusion. All of these factors are aggravated by traumatic or surgical perineural scarring, loss of disc height, distortion of the foraminal volume, and the disc only appears to be tender in 11% of cases. And instability is again a misdiagnosis of foraminal nerve pain treatable by foraminoplasty. But spinal pain can be mimicked by the cluneal nerves. Here, they cause pain where the nerve transits fascia, particularly when the patient has developed malposture. The trigger points can produce very significant pain, both in the back, the buttocks, and the legs, as you'll see here, with pins and needles, pseudo-numbness, and loss of spatial awareness. So I needed a diagnostic cascade to try and identify the cause of the pain. This, of course, started with clinical examination to determine the pain center. So if the facet joint displacement aggravated the pain, I would conduct a CT-guided facet joint block, making sure that the steroid didn't creep into the foramen or pass through a defect in the capsule. If the result was positive, then we would conduct a radiofrequency ablation, but if this failed, then consider the patient for foraminoplasty. If midline displacement caused the pain, then a CT-guided nerve root block would be performed transforaminally, not as an epidural. The epidural is far too limited in defining location. And if this was positive, then consider the patient for foraminoplasty. Equally, if the iliac crest palpation reproduced the pain, then to carry out nerve blocks at those points of sensitivity, and if this was able to relieve the patient's pain, then consider carrying out nerve radiofrequency ablation. And if this failed to completely relieve the symptoms, again to consider the patient for foraminoplasty. I hope this helps, and many thanks.